Fantástica pues presentación del Dr. Rey Panettieri, estadounidense de la Universidad de Pensilvania, es profesor de la Universidad de Pensilvania, es director inaugural del Instituto de Medicina y Ciencia Translacional, vicerrector de Medicina y Ciencia Translacional en la Universidad de Rutgers, profesor de Medicina de Robert Wood Johnson Medical School, y se desempeñó en algún momento como director de la Iniciativa de Biología de las Vías Aéreas de la Universidad de Pensilvania. Él nos va a hablar de una lectura de los mecanismos de remodelación de la vía aérea. Si necesitan equipos de traducción simultánea, ahí los están entregando.
Very good. Can everyone hear me? Okay? See. Thank you so much. Thank you so much for being here. And I wanted to say Dr. Duran and Dr. Fernandez did a very nice job talking about endotype and phenotype. I am going to talk about the nexus or the connection between airway remodeling and irreversible airflow obstruction in severe asthma. These are my disclosures. None of these will impact on this talk. We will talk about inflammation and progression in disease. You as healthcare providers see patients with severe asthma. The question is, do these patients progress in their disease? We will talk about the types of inflammation, and then at the end I will speak of work that we have done to show that irreversible airway obstruction has nothing to do with airway remodeling. We use the term airway remodeling to mean irreversible airflow obstruction, yet our data to support that is quite weak. So again, we will talk about inflammation, characterize airway remodeling and inflammation, and talk about non-T2 and T2 inflammation. Asthma is a syndrome. No one gene tells you whether you have asthma or not. It requires a healthcare provider to understand whether a patient has reversible bronchoconstriction, hyperresponsiveness, and airway inflammation. There is no one gene. There are clusters of genes that might be helpful. Our concept of the onset and pathogenesis in asthma is shown here. Environment and gene interactions induce asthma, meaning if I had identical twins at birth, one leaves Cartagena and goes to the Arctic, the other stays in Cartagena. That twin in Cartagena, because of the environment, gets asthma. That individual with the exact same genes in the Arctic does not. That means environment-gene interactions cause asthma. Now, most asthmatics, 85%, sustain a viral infection and get better. 15% go on to develop irreversible airflow obstruction. 15% of a common disease. Now, we believe there are other genes that make you susceptible to irreversible airflow obstruction. Manifestations are more muscle, more matrix, more vessels, more goblet cells. But the vast majority of patients with asthma do not go on to develop irreversible airflow obstruction. That is shown here. Looking at age and lung function with time, as we get older, everyone loses lung function. Everyone. Our lungs sag, wrinkles. Unfortunately, asthmatics, even treated, lose lung function at a fast rate. But it is not a constant progressive loss. It is an exacerbation with incomplete resolution of the exacerbation. We see that and heard about that in the last talk with cystic fibrosis. You see that with multiple sclerosis. In individuals who have an exacerbation, they don't get complete resolution. We believe frequent exacerbations in susceptible individuals lead to irreversible airflow obstruction. So what does that mean for you as a provider? At all costs, eliminate exacerbations. If you eliminate exacerbations, patients won't progress to irreversible airflow obstruction. Very important. It's more complicated than that. It depends on when that patient sustains a critical exacerbation. For example, 3 patients, A, B, C. A, no asthma. Everyone's lungs develop until you're age 18. After age 18, everyone's lung function declines with age. This is a normal patient. Patient B had an injury early that did not allow the lungs to develop or the airways to develop normally. As a consequence, they did not get to a normal level in adulthood, and then because of the inexorable loss in lung function over time, you see they crossed the line of disability later in life. But what they lost early in life. C, patient C, had severe exacerbation under the age of 2. Their lungs and airways did not develop, and then at age 40, they develop irreversible airflow obstruction and disability. So when you see a patient with severe disease, with severe loss in lung function, recognize that that may have occurred 20 years before. So we can't restore that function, but we could prevent worsening of the disease with less oral steroids as necessary. Now, we've talked about that. Let's talk about the links between asthma, remodeling, irreversible airflow obstruction. This is a child I took care of, 8 years old, who had severe asthma. He had a bronchial carcinoid, benign tumor that needed to be removed, but it gave me the opportunity to look at his airways. Look here. This is subbasement membrane fibrosis. 40-fold increase in this child. Normally, this is the size of a pencil line. This is 40-fold increase. Look in the submucosa, neutrophils, T lymphocytes, eosinophils, and smooth muscle. This is airway remodeling. Now, what component of this leads to irreversible airflow obstruction? We know there's more muscle, more vessels, more goblet cells, more scarring, but the data to support that any one of these is critical in manifesting the phenotype of irreversibility is unclear. Now, the sequela of allergen T2 inflammation is shown here. Leukotrienes are secreted by a variety of cells, and mast cells cause bronchoconstriction, more mucus. Each of these could contribute to airway remodeling, but the relative consequences of any of these is unknown. We believe the resident cells, smooth muscle, mast cells, play a seminal role in orchestrating and perpetrating the inflammatory response. As trafficking immunocytes come into the airways, they communicate with the smooth muscle, the goblet cells, in a way that then sustains this phenotype of asthma. Now, in this cascade of resident cells, structural cells, and trafficking cell, the eosinophil is very important. It secretes PDGF, a growth factor for smooth muscle. It can also secrete and respond to a variety of cytokines that continue to perpetrate the inflammatory response. Very complicated slide. The only thing I want you to notice is that the eosinophil does play a seminal role in integrating these signals. Dr. Duran showed you the alarmins, IL-33, IL-25, TSLP after epithelial injury can induce an inflammatory response. This occurs without allergy and without allergen. So let's now move on and recognize, and I believe Dr. Maria Fernandez showed this slide. There is T2 inflammation and non-T2 inflammation. We believe non-T2 inflammation is driven by epithelial injury manifested by TSLP, IL-33, and IL-25. No inflammatory cells. Direct injury on the epithelium sustains this ongoing inflammation. In this case, the ILC2 cells are very important. They can communicate with trafficking eosinophils through IL-33 secretion, IL-4 secretion to change the phenotype of the smooth muscle. Here, demonstrating the role of IL-5 in infection and allergen, one gets secretion of IL-33. This is an epithelial cytokine that perpetrates the inflammation. This occurs with pollution. High ozone levels can sustain this injury. Now, TSLP is very interesting. A new monoclonal antibody is being developed against TSLP. For the first time, this will be a non-T2 monoclonal antibody that we will have opportunity to use. Very exciting. TSLP can affect IL-13 secretion by the mast cell, as well as dendritic cell function and basophil function. So what we tried to describe here is this interaction of pollutants and infection, viruses, damaging the epithelium, and the T2 inflammatory cascade. Let's spend the moment on the eosinophil. Eosinophil is central to the inflammatory response. It secretes TGF-beta. I'm going to come back to that in a moment, very important. But it also promotes angiogenesis and growth of the smooth muscle. Now, the eosinophil targets IL-5 receptor, CCR3 or the eotaxin receptor, as well as CRTH2, the ligand being DP2. These are important to you because new drugs are coming out that target these specific moieties and receptors. This is all on the eosinophil. So what we've tried to do here is relate virus-mediated TSLP, T2 signals, all of which converge on the eosinophil. The mast cell also plays a seminal role. The mast cell can modulate T2 responses as well as some of the non-T2 responses. Mast cell degranulation is steroid insensitive. So when you see a patient who is not responding to steroids, unlike the eosinophil patient, these patients may be mast cell driven. So what I want to talk about now is our work that addresses irreversible airflow obstruction. And how do you get there with no inflammation? I am going to talk about airway smooth muscle. The work we do is done in human airway smooth muscle. We get human lungs harvested every 2 weeks. These are aborted lung transplant. We then inflate the lungs with low melting point agar, slice them into very small slices, 300 micron, human lungs. We then give carbachol. You're familiar with methacholine challenge. This is a methacholine challenge in a petri dish using human lungs. And what I can get is marked constriction of the lumen of the airway as I increase my dose of carbachol. Now, if I use a beta agonist, I can completely relax this. This is in a petri dish, but it gives me a model to study irreversible airflow obstruction. When we give these slices, TGF-beta is secreted by damaged epithelium, eosinophils after degranulation. TGF-beta by itself decreases luminal diameter. This is normal. This is after TGF-beta. You can see that TGF-beta overnight makes the airways tighter. Now, where does that happen? When you see a patient with a viral infection, they manifest sustained airflow obstruction for weeks, even despite steroids. Now, if we see the agonist-induced bronchoconstriction, this is normal. If I give TGF-beta, we amplify that signal. That is shown here. And we see it augmenting carbachol-induced responses. How does airway smooth muscle constrict? It constricts by the activation of a GPCR, G protein coupled receptor, that increases calcium and promotes contraction. Another pathway that occurs simultaneously has nothing to do with calcium. It activates Rho kinase, inhibits a phosphatase, and sustains constriction. Now, TGF-beta activates this pathway through SMADs that cause gene expression. What we now show is that this pathway, after an asthma exacerbation, is very active, and it can impact on the muscle's responsiveness. Shown here, TGF-beta that causes constriction of the muscle has no effect on calcium. This is methacholine, increases calcium. TGF-beta, no effect on calcium. So TGF-beta is inducing this by not changing the calcium in a cell. It also doesn't have any effect on histamine in this case. Now, when we looked at activation of this pathway, what we found is that Rho A was not affected in the phosphorylation of light chain. This is the last step that causes constriction of the muscle, shown here. So that was not involved. But when we took out the receptor of TGF-beta, we found that it markedly decreased the amplified signal. That was shown here in knocking down this particular SMAD that actually signals. SMAD2 had no effect. So this is a SMAD3 effect. Very exciting to us. What it suggests is TGF-beta, after viral exacerbations, make the muscle more responsive and makes contraction greater. Let's now move on and look at relaxation, because remember, irreversible airway obstruction is when you give a bronchodilator and the FEV1 does not improve. So what happens if we give TGF-beta? Well, let's stop here and show beta agonists increase cyclic AMP, and this can impede contraction of muscle. But if TGF-beta is present, the ability of a beta agonist like isoproterenol, formoterol, or anything that increases cyclic AMP is half as effective, meaning that beta agonists won't work when TGF-beta is present. That is what you see in the clinic after a viral infection where there's sustained airflow obstruction and the patient's pre-post bronchodilator doesn't work. This has nothing to do with the growth of muscle or matrix deposition. Matter of fact, here we're looking at how TGF-beta blunts this signal, and it's quite profound. Now, what we noticed is TGF-beta causes phosphodiesterases to go up. Phosphodiesterases break down cyclic AMP. And in human airway smooth muscle, after TGF-beta exposure, we found there's a dramatic increase in phosphodiesterase 4D expression. If we take out this component of TGF-beta signaling, sure enough, we knock that down and we restore the responsiveness. So, what I have shown you is that I can make muscle more responsive to all contractile agonists in the presence of TGF-beta that is found after viral infections or ozone secretion or even after allergen exposure, and that TGF-beta renders beta agonist bronchodilation markedly attenuated. So, TGF-beta, we feel, apart from any airway remodeling, can make contractile responses more robust while inhibiting the effects of beta agonists. These are my team that allows me to come to Columbia and present to you. I want to thank you all very much for this wonderful opportunity. Thank you.